Thank you very much, and thank you for the organising committee for inviting me to this really fascinating meeting. I better crack on. So imaging, we're going to be talking about the way in which imaging can help in primary prevention, and certainly I think we have to say something about compliance and then improving risk stratification, and also the fact that it's somewhat a headache sometimes, as Andrew's already alluded to. So in terms of compliance, I think you can show this to a patient, lifetime risk with increasing risk factors, and it looks very impressive, particularly if you have a lot of risk factors. But, people are actually very used to dealing with risk, and you can draw in the other bit of this curve, and you can come up with a statement such as, if you have a high cholesterol and you smoke, you've got a 58% chance of living till the age of 80 without having a heart attack and a stroke. So, if you're not particularly keen on taking tablets, that's really a little bit of the dilemma we face. However, I think we are increasingly living in a visual society, and if you show patients their CT calcium score and you show them that there's something unpleasant happening in their coronary arteries, there's a fair bit of observational data now showing that you can actually significantly improve their compliance, even with something like dietary modification. You can see as the calcium score goes up, actually it's really nicely shown here, as the calcium score goes up, the compliance increases very nicely, both with exercise and diet. And this is another study looking at increased exercise, diet, and aspirin initiation at a slightly larger number of patients that showed something similar. There's a slight, significant differences at the end, but there's a slight aspect of survivor bias in here. Still, I think this is interesting, and potentially, particularly for primary prevention patients that actually are not patients because they're not sick, they feel well. I think by showing them what's going on in the coronary arteries, you can maybe change that perception. Now, what about improved risk stratification? Well, again, how do we distinguish or be able to better refine this kind of risk stratification, which is really about statistical profiling? That's what we're doing when we're taking risk factors and calculating risks for patients. The fact is that atheromas start forming probably even before puberty, and it's an ongoing process. And patients come to cardiologists at the point where they develop symptoms. But of course, we know already from histological studies and so on that there are a lot of aspects of plaque that are associated or contribute to the progression and also the destabilization of plaque. And we have now a whole host of tests, both invasive and non-invasive, that can measure different aspects of plaque or even several aspects of plaque in great detail. I think when thinking about primary prevention patients, certainly probably invasive imaging is a step too far, but again, there's a lot of interesting things we can talk about in non-invasive imaging. Something as simple as just measuring the amount of calcification in a plaque, which probably represents about 20% of plaque overall, is a profoundly effective way of stratifying risk, and certainly patients with no coronary calcium seem to do extremely well. How does that work when you add it to statistical risk profiling? There's quite a few studies now in several thousand patients basically showing that for every Framingham risk category, whether it's low, intermediate, or high, differentiating between low, intermediate, and high calcium is again, within every Framingham risk category, a profoundly good way of stratifying risk. And it's, since the talk is supposed to be on the high-risk primary prevention patient, if you take the high-risk primary prevention group here, high-risk Framingham score, you can see that their average event rate is not dissimilar from a sort of intermediate calcium risk group in the low Framingham risk groups. It's not dissimilar from the low-risk patients, actually. And I suppose the other thing is calcium score, the patients that get mostly reclassified are the intermediate risk group, but approximately it's over 30% of the high-risk Framingham risk, clinical risk score group get reclassified simply based on a calcium score. So we can also think about other ways of selecting high-risk primary prevention patients. So diabetes is sometimes thought about as a cardiovascular disease risk equivalent. We can see in people with diabetes, again, that calcium is a profoundly good way of stratifying risk. There's a fair few studies consistently showing that at any given level of calcium score, coronary calcium score, that people with diabetes have a higher risk than people without diabetes of cardiovascular events and, in fact, all-cause mortality. We'll move on a little bit later. I'll show a bit better data on patients with a zero-risk score. We can also look at plaque in a bit more detail using CT coronary angiography. And again, this graph looks at revascularization, death, and MI. You can see that having no one or two vessel disease is a profoundly good way of risk stratifying. And if you simply look at death or MI, again, it's a very good risk stratifier. This is from the CONFIRM registry, which is just a small subgroup of people with diabetes, about 400 out of 27,000 patients. But they had to have diabetes and be asymptomatic and have no prior cardiovascular disease, which is why it's a relatively small number. But if you look at the C statistic for predicting events for just clinical risk scores, 0.64. If you add in calcium score, it goes up to 0.74. And if you add in the number of obstructive vessels from CTA, you go up to 0.78. What is also very interesting about this is if you look at which patient groups the reclassification actually happened, there was virtually no reclassification by the CT angiogram data in the low calcium score patients, but in patients with an intermediate to high calcium score, a significant amount of reclassification based on the CT angiogram data. And these certainly were high-risk patients. I mean, Framingham risk scores 21, European heart scored 15, calcium scores of 0 and 36%, and no coronary artery disease in only 30%. What about CT angiography? Well, there is a lot of different ways of looking at plaque and how do you actually score it? A lot of different ways. So this is an interesting study from, in fact, South Korea. And they looked at simply the severity of coronary artery disease, the number of obstructive vessels, whether it's located in the left main or proximal, whether it's defined as high risk based on something like a CT syntax score, the number of segments involved. The Duke prognostic score is actually something we use with coronary angiography and interventional cardiology, and they modified it to apply to CT. But the good news is that something very simple, simply reporting the number of obstructive coronary arteries on a CT actually gave the best C statistic. Admittedly, there's not too much between some of these parameters, but just calling out you've got one significant vessel is pretty easy to do. So more data from the CONFIRM registry. In this case, we've got a propensity matched study of about 1,800 patients with diabetes, propensity matched with 1,800 without. And I think the propensity matching seemed to work reasonably well in terms of if you looked at the number of vessels that were diseased on CT, the distributions are very similar between the people with and without diabetes. Now, what is interesting from this particular study is if you look at the annualized event rates, and in this case, they looked only at absolute mortality. They didn't have cardiovascular death. You can see that the event rates for people without diabetes and with diabetes, there's a slightly higher with the diabetes, but if you look at the confidence intervals, there's a lot of overlap in people with normal coronary arteries. On the other hand, if they have any kind of plaque, whether it's non-obstructive or obstructive, people with diabetes have a very significantly higher event rate, both for non-obstructive and obstructive disease when compared to people without diabetes. So basically, what you can conclude from this is even people with diabetes are generally at very high risk. If they have no coronary artery disease in a CT angiogram, their prognosis is actually pretty good. So this is a bit more data, which is somewhat disconcerting. It's from the Netherlands, some of my old colleagues in Rotterdam. Basically what they did is they selected patients with a high primary prevention patients, so some with FH or several risk factors. And they followed them up for, I think, 3 years. And they all received intensive lifestyle counseling, medical therapy at baseline, and strict compliance was ensured by regular outpatient visits. What is interesting is that the people without without coronary disease or a low disease burden did very well with good risk factor control. But people with obstructive coronary disease on CT, asymptomatic patients, didn't do very well at all. So there's clearly a group there that we need to find a way of identifying them prior to the point where they reach obstructive disease. What about patients with familial hypercholesterolemia? Well, patients who have gene mutations seem to have extremely high event rates, so probably they're not people you necessarily want to consider doing imaging on. There's a lot of tiny studies reporting the incidence of calcium, positive calcium, and coronary disease, and they consistently report higher rates than people without. But we actually have no data trying to use imaging to determine whether all patients with FH need to have intensive risk factor or lipid modification at all times. We can try and say that perhaps patients with polygenic hypercholesterolemia, there is potentially a role, but certainly we need to generate the data for that. Can we extrapolate from other data? Well, there's several studies now in a fairly large number of patients. If they're asymptomatic and they get calcium scores, well, the graph's chopped off, but somehow. If you have a calcium score of 0, up to 12 years, your event rate's below 1%, actually. It's quite remarkable. 15 years warranty-free period. 15 years warranty-free period. That's pretty impressive, I think. Does that apply to everybody? Well, gut feeling as a clinician says no. And of course, if you look at patients with a calcium, this is a different study, by the way, 10,000 patients, again, asymptomatic. If you simply look at the patients with a calcium score of 0, and you look at event rates, patients with a low, intermediate, and high Framingham risk score had progressively higher event rates. And I think it's fair to say that somebody with a high Framingham risk score has more risk factors or poorly controlled risk factors compared to somebody with a low one. So to me, this suggests that modifiable risk factors are likely to affect your warranty, right? Your investment can go up as well as down, I suppose. What is interesting of this paper is they actually try to translate this into a bit more meaningful information. So what you can see here is patients with a calcium score of 0, if they have a low Framingham risk score and they have a calcium score of 0, their chances of exceeding an annualized all-cause mortality rate of 1%, it doesn't happen up to 15 years. Similarly, if you have a calcium score of 0 and an intermediate Framingham risk score, you get a 15-year warranty. If you have a high Framingham risk score and a calcium score of 0, you've got a 5-year warranty. On the other hand, if you have anything in your coronary arteries in terms of calcium, it's just more than 0, you don't have much of a warranty at all. In fact, even if you're low risk, the best you can get up to is 4 years. And bear in mind that this is a calcium score of more than 0. So certainly, the higher the calcium score goes, the lower that warranty is going to be. So I've not shown, for the sake of time, the rest of this table, but it's fascinating because they also provide similar warranties, if you want, using ATP3 risk stratification or age or gender. I think it's a fascinating approach. It's a single center study, okay, so there's potentially several biases involved, and also, again, they only have data on all-cause mortality. So I think it's a fascinating approach, and I think we need a lot more of this sort of data. Progression of coronary calcium. Well, this is particularly fascinating. Just for having this discussion, is calcium good for you? Does it stabilize plaque or not? Well, this is very interesting. If you have progressive plaque versus non-progressive plaque, you can see that for every level of coronary calcium, the prognosis is dramatically worse, okay? But note here, even in people with non-progressive plaque, people with high calcium scores don't do very well compared to people who don't have calcium. What is perhaps also not surprising is the rate of increase in calcium, or the event rate, parallels the rate of increase in calcium. It's not surprising. The faster the atherosclerosis progresses, the worse you're going to be doing. I find this particularly fascinating. This is sodium fluoride PET on the aortic valve, so patients at baseline who had high uptake of sodium fluoride PET, which detects not calcium, but the process of calcium being formed in the artery. So there's no calcium yet, but what this study showed is within 14 months, patients with hot spots developed new calcium, and very importantly, there was no new calcium formation in parts of the vasculature where there were no hot spots, no increased PET uptake. So this is interesting because doing serial calcium scores 3 years apart is perhaps inconvenient for clinicians and also for patients, but potentially with sodium fluoride PET you can detect who's going to be progressing at baseline. Very interesting. We don't have enough data yet to know if that's actually true. We know that this stuff is taken up in coronary arteries, certainly is in patients with acute coronary syndrome, and there's some studies looking at the predictive value of that in acute coronary syndrome. Is there any primary prevention data? Well, I'm also going to raise this question: can we use imaging to monitor response to therapy? And I'm going to try and answer both questions, hopefully. So in Western Australia, we're doing this randomized trial. So patients with diabetes are being selected. And I'm going to take another 2 minutes. If they have an elevated calcium, they get a sodium fluoride PET scan, and they then get randomized to a vitamin K or an anti-inflammatory colchicine or the combination, and we repeat the sodium fluoride PET. So the idea is to see if we can switch off this process of calcification, which I think is interesting on its own right, but we will also learn something about the natural history and, with long-term follow-up, also the predictive value of the sodium fluoride PET in a high-risk primary prevention cohort. So, as Andrew's alluded to, patients come to you with their positive calcium scores. Some of them have extremely well-controlled risk factors, and it's a bit of a headache if you don't know what to tell them anymore, but I think it's an area for research, rather. We need to find better ways of identifying why some of these patients have such a high risk. In conclusion, imaging can significantly improve risk stratification. Absence of calcium on CT or coronary artery disease on CTA certainly portends a very good prognosis. Modifiable risk factors are likely to affect your warranty. We need a lot more studies that include changes of risk factors over time and in specific high-risk groups. And you can help to improve compliance by showing patients their bad scans. Thank you.
Thanks very much. We've got time for some questions. Jonathan?
Yes. Tell me about vitamin K.
Vitamin K is fascinating in that it